Chest pain is not just pain, it can mean heart muscle is dying, minute by minute. Today, we master acute coronary syndromes, slowly, clearly, nothing skipped. What is acute coronary syndrome? Acute coronary syndrome is not a single disease. It is a clinical spectrum. All conditions in this spectrum have one common mechanism. A thrombus forms on top of a ruptured atherosclerotic plaque inside a coronary artery. That thrombus suddenly reduces blood flow to the myocardium, and when myocardium does not receive oxygen, ischemia begins. If prolonged, necrosis occurs. That is ACS. The three conditions in ACS includes three major conditions: STEMI, ST segment elevation myocardial infarction; NSTEMI, non-ST elevation myocardial infarction; unstable angina. They all start the same way, but they differ in severity. How do we diagnose ACS? Never forget this triad. This is a favorite exam point. Definitive diagnosis is based on 1. Clinical presentation, 2. ECG changes, 3. Cardiac biomarkers, especially high-sensitivity troponin base. If you forget one of these, diagnosis becomes weak. Troponin is extremely important because it tells us whether myocardial necrosis has occurred. Pathophysiology, what actually happens? Let us imagine the artery. Inside the coronary artery, there's an atheromatous plaque. One day, the plaque ruptures. When it ruptures, subendothelial collagen becomes exposed. Platelets immediately activate, they aggregate, coagulation cascade starts, a thrombus forms. Now blood flow becomes obstructed. The severity of obstruction determines what type of ACS we see. STEMI. In STEMI, the blockage is complete and persistent. There is total occlusion of the coronary artery. Because of that, full-thickness myocardial necrosis occurs. This is called transmural infarction. On ECG, you see ST segment elevation. This is a medical emergency. Time is muscle. Every minute of delay increases myocardial death. NSTEMI, the blockage is partial or sometimes intermittent. Blood flow is reduced but not completely stopped. However, it is still enough to cause myocardial necrosis, so troponin is elevated. ECG does not show ST elevation. Instead, you may see ST depression or T-wave inversion. Important exam differentiation. NSTEMI equals troponin positive. Unstable angina. In unstable angina, there is partial blockage, but there is no myocardial necrosis. That means troponin is normal. ECG may be normal or may show ST depression. So what differentiates NSTEMI and unstable angina? High sensitivity troponin. NSTEMI positive, unstable angina negative. Very high yield exam concept. Initial management of suspected ACS management begins immediately. Do not wait. Do not delay hospital transfer. The goals are relieve pain, prevent clot progression, stabilize the patient. Pain relief first, give glycerol trinitrate, sublingual or buccal. It works quickly. If pain is severe, give IV morphine. Pain control reduces sympathetic stimulation and reduces myocardial oxygen demand. Antiplatelet, first critical step. Give a loading dose of aspirin immediately, as soon as possible, even before hospital if available. Document it. Other antiplatelets should be started in hospital. Aspirin is life-saving here. Oxygen is not routine. Monitor saturation. Give oxygen only if hypoxic. Unnecessary oxygen can actually cause harm. Hyperglycemia monitoring. All admitted patients must have glucose monitored. If glucose is more than 11 millimoles per milliliter, start insulin. Preferred dose-adjusted IV infusion. Hyperglycemia worsens outcomes after MI. STEMI management. Now this is critical. The goal is simple. Restore coronary blood flow fast. Reperfusion therapy must be given as soon as possible. Two options exist. Primary PCI, preferred fibrinolysis. If PCI not available, primary PCI is preferred if, within 12 hours of symptom onset, can be performed within 120 minutes, because PCI directly opens the artery. Antiplatelet therapy in STEMI. Always dual antiplatelet therapy. Aspirin plus prasugrel, ticagrelor, or clopidogrel. Prasugrel is preferred in primary PCI unless bleeding risk is high. High bleeding risk, sometimes aspirin alone may be used. Anticoagulation during PCI. If radial access, use unfractionated heparin. If femoral access, bivalirudin may be considered. GP2B3A inhibitors are bailout therapy. If fibrinolysis is used, an antithrombin must be given at the same time. NSTEMI and unstable angina. These are managed similarly. Goal, prevent further infarction and reduce mortality. Risk assessment is essential. High-risk patients go for early angiography. Antiplatelet therapy. Again, dual therapy, aspirin plus prasugrel, ticagrelor, clopidogrel. Choice depends on PCI planned or not, bleeding risk. High bleeding risk, consider aspirin alone. Antithrombin therapy fondaparinux is preferred unless immediate angiography is planned. Severe renal impairment, use unfractionated heparin. Very important exam point, if patient received fondaparinux at its size and then goes for PCI, you must still give unfractionated heparin in the cath lab. Students forget this. Secondary prevention after ACS. This is extremely important because survival does not end at discharge. All patients must receive cardiac rehabilitation, lifestyle modification, risk factor reduction, advise healthy diet, stop smoking, reduce alcohol, exercise regularly, weight control, stress management, long-term drug therapy. After STEMI or NSTEMI, start 4 major drugs: 1, ACE inhibitor; 2, beta blocker; 3, dual antiplatelet therapy; 4, high-intensity statin ACE inhibitor. Start once hemodynamically stable. Continue indefinitely. If intolerant, use ARB. Prevents remodeling, reduces mortality. Beta blocker, start when stable. If reduced LVEF, continue lifelong. If normal LVEF, may stop after 12 months. If no LV dysfunction and cannot use beta blocker, diltiazem or verapamil may be used, but never use them in reduced LVEF or pulmonary congestion. Antiplatelet duration. Aspirin, lifelong. Dual therapy, usually 12 months. Aspirin allergy, use clopidogrel alone. Selected high-risk patients may receive rivaroxaban additionally, but always balance bleeding risk. Statins. All patients with cardiovascular disease must receive statins. High-intensity statin is usually required. Stabilizes plaque, reduces recurrence. Fibrinolytic drugs used when PCI is not available. They convert plasminogen to plasmin. Plasmin breaks fibrin. Clot dissolves. Examples: streptokinase, alteplase, retaplase, tenecteplase. Best benefits seen in ST elevation, anterior MI, bundle branch block. Time window is critical, ideal time within 1 hour. Age alone is not a contraindication. Contraindications: must know aortic dissection, active bleeding, recent surgery, recent trauma, severe hypertension, recent cerebrovascular disease, bleeding disorders, bacterial endocarditis, aneurysm, acute pancreatitis. These are exam favorites. Major side effects: hemorrhage, CNS bleeding, hypotension, cardiogenic shock, reperfusion arrhythmias, myocardial rupture. If serious bleeding occurs, stop the drug immediately. Nitrates in ACS used mainly for symptom relief. But remember this carefully. Their major benefit is not only coronary dilation, they reduce venous return, reduce preload, reduce left ventricular workload that decreases myocardial oxygen demand. Forms include sublingual GTN, spray, transdermal patches, isosorbide dinitrate, isosorbide mononitrate, IV GTN in unstable angina, IV nitrates in heart failure. Side effects: headache, flushing, hypotension, dizziness, syncope. Tolerance develops, so always provide a nitrate-free interval 4 to 12 hours daily. Never stop abruptly. Monitor blood pressure during IV infusion. Final clinical understanding: ACS begins with plaque rupture, then thrombus, then obstruction. STEMI, complete blockage. NSTEMI, partial blockage with necrosis. Unstable angina, no necrosis. Immediate steps: aspirin, GTN, morphine if needed. Assess oxygen, monitor glucose. If STEMI, reperfusion urgently, then dual antiplatelets, anticoagulation, and lifelong secondary prevention. This single topic can produce multiple MCQs, and in real clinical life, it is the difference between life and death. If this video helped you understand acute coronary syndrome clearly, then please support the channel. Like this video, share it with your friends and classmates, and subscribe for more simplified medicine lectures, one topic at a time. We learn slowly, we learn clearly, and we learn to save lives. I will see you in the next class.